We're really excited to have a room full of people. My name is Kelly Eyre. I'm the marketing director here for Arbor Hospice. And before we do anything, I want to just ask one quick question. Do we have any veterans in the room? Oh, any family members of veterans? Raise your hand. Okay, veterans and families of veterans, please stand up. Let's give you guys a round of applause. Okay, so we are going to get started. We are thrilled to have some guests here today to talk about end of life and palliative care and hospice and what that looks like. Just to give you a real brief sort of history on how this all came about, Gloria and Kathy came to the open house that we had here at our Oak Valley building a couple of months ago now, and we sort of by happenstance met each other, and they were talking about their passion for end-of-life care and hospice care and getting the word out in the community, and their passion and desire to really, kind of do this grassroots just moved me, and I said, I want to be involved somehow. However it makes sense for us to be involved, I want to be involved. So that's sort of how this all started. You guys are here today. We are hosting this event, but this is really an event for all of you to learn more about services that are available, information, getting informed, getting educated, so that when that time comes for you, you'll be more knowledgeable and better, be able to make choices on what you'd like to do. So with that, just a couple of housekeeping things. Straight out the door, you kind of go straight in a wiggly line. The restrooms are right through there. We have lots of staff here that can help direct you if anybody needs to be directed and where to go. Also, the elevator is just straight out the door also to go back up. Most of you probably parked out in the front, but we also have the parking lot out in the back. We'll help you get to where you need to go. Beverages and snacks and whatnot are in the back. We also have a resource table on the side here with different things, pads of paper, pens. We are going to ask that you write down your questions as these ladies talk about the things they want to talk about, and then we'll do a Q&A at the end. So if you think of questions during the presentations, we ask that you write it down on a pad of paper, and then we'll go through it at the end. Also, a quick thing about cell phones, make sure your cell phones are turned off or on silent. That would be helpful. And I think that's it. So with that, we will go ahead and get started. So Gloria Zimmett and Kathy Achino are going to start us off. Dr. Raquel Clary-Lantis is here. She's from St. Joseph Mercy in Ann Arbor. She's head of the palliative service there at the hospital. And then Mary Lynn Rush, our sort of celebrity here. Death Doula, the Ann Arbor Death Cafe she started, so a lot of you probably have heard of her. I'm really looking forward to what all of these ladies have to talk about today and learn a little bit more myself on everything. So with that, I'm going to hand it over to Gloria.
Hello everyone. I'm excited. It's great to see this lovely turnout. Surprising note, as you've heard how this came to be when Kathy and I met Kelly unexpectedly. I never imagined that I would be instrumental in any way in organizing a conversation about palliative care and hospice. There are organizations like Arbor Hospice which so generously offered to host this event. There are staff members who have far more knowledge than Kathy and I do about this, and people much more qualified in the community. But something happened this spring when a woman that I know shared a circumstance that was happening with her elderly husband who was receiving radiation and chemotherapy for his, radiation and surgery for his skin cancer. Even though his condition was very frail. And when she continued and told me that the radiation oncologist had told her that he considered palliative care, he considered that the radiation was a form of palliative care, something inside me snapped. I couldn't believe that the term palliative care So what happened is that when I heard this terminology, palliative care, which I had one impression of its meaning, used to describe a form of radiation which has pretty detrimental effect on the body, particularly on the skin, and particularly for a man who was very elderly, I knew that I couldn't sit back any longer and be quiet. And that's when I called Kathy. Because we have similar stories, as you'll soon hear, and we both have this desire to make sure that everyone in the community knows about palliative care and is informed of it and can advocate for it and get these resources when needed. And that we won't be in a situation like this woman that I referenced, who was told by a physician that what they were about to be doing for her husband was anything but. So we hope that as Kathy and I share our personal stories, there will be something that rings true for you, maybe something that, and when I share what happened when my husband was diagnosed with brain cancer over 10 years ago, something that will feel familiar to you, something that you'll feel like, I wish I would have said that, something that will motivate you to reach out and access these services that I didn't know and Kathy didn't know were available. And another goal of ours is to help remove some of the fear and the stigma that's sometimes associated with these services. And in general, kind of a queasiness and uneasiness to talking about death. So the date 777 is etched in my mind. It's a date that many people find really special because of the 3 consecutive sevens. Special events, weddings are often purposely hosted or planned around that date. And for me, unfortunately, that's the date that I remember because that's the date when my late husband Nathan was diagnosed with his cancer. And I'd like to share with you some of the important milestones in the 20 months that he lived afterwards, so that you have a sense of what the system looked like and how the medical system so aggressively pushes medical treatment to the exclusion, in our experience, of almost anything else. So he received brain surgery to alleviate the pressure that the tumor was causing. That was quickly followed by radiation and chemotherapy. And those treatments didn't work so well, and fluid accumulated in his brain, and he needed to receive yet another surgery. And that was to insert a tube inside to help the fluid drain. That was short-lived as well, and there needed to be a repeat visit in order to drain the fluid. He used some holistic types of anti-cancer treatments. We went to a new cancer support group, both he as the patient and myself as the caregiver, to help us cope with what was happening. He met with a psychotherapist. There was a long list of treatments and approaches that he had. And something noteworthy about the second brain surgery that he had, his neurosurgeon commented that in the realm of brain cancer, there's no science, there's only hope. And that's a quote, those few words. Yet there was no mention of anything, any resources that could be done or offered, even when he was as bold and honest to have admitted that. So you have kind of a taste of what it was like, really in summary, to be part of the medical system where with his type of brain cancer, even with the abysmal prognosis that it has, and it's less than 10% survival rate, these therapies.
No, that mic is being.
So that was in the first year or so, and after about a year and a half, there were signs that the cancer actually was returning and he was experiencing vision loss. He was ultimately unable to stand, and at that point he was admitted to the hospital. And pretty much at that point, my normally optimistic nature had really switched, and it was clear that he was no longer going to be able to survive this. Yet in the medical community, there was no acknowledgement of that, even though they were seeing the exact same symptoms as I was. No willingness to address what we would call the elephant in the room. And he, at that point, was in a rehab facility with the intention of the medical community to help him learn how to walk. In their minds, I guess, imagining that he was going to live long enough to be able to make those efforts worthwhile. And I sensed what was happening, and I requested from the physician who's the head of rehab to please have to please schedule a session to speak with my son. So I have 3 sons, and I wanted them to hear from a medical professional what was happening, to hear that their father, his life was coming to an end. So he agreed to do that, and when they were there, he sidestepped the issue completely. And my sons left wondering why I dragged them into this meeting and what the doctor had in mind. I say this to give you a taste of what it was like when even people in the medical profession, the ones that we count on to be able to help us go through this, are unavailable, even when they've said that they would be. So this particular one wasn't a surprise. And what's missing from this kind of little scenario that I just painted for you is what life was like for myself and my sons as all this was going on. And it was extraordinarily difficult. We were really living between surgery, treatments, recovering from those treatments, side effect from medications used for those treatments, finding out about cancer support communities, trying to avail ourselves of all of the resources. That was basically what life looked like. It was very difficult, and it was difficult even with incredible support from this community. Some of who are in this room right now, and I thank you for that support. So another point that I want to mention is that throughout this time, I was constantly requesting emotional support for my husband, not knowing that there was such a thing as palliative care, but knowing that he could benefit from that to augment the therapies that he was receiving. And despite those requests, despite this picture that I painted, there was not one time, not one individual in the 20 months where he was alive, where anyone ever mentioned palliative care. So we're talking about his primary care doctor, we're talking about 2 neurosurgeons, neurologists, ophthalmologists, social workers, chaplains, the list goes on. There wasn't a single individual who mentioned it until a friend of mine who had heard me, pretty much in exasperation, tell her the latest installment of what was happening, asked me if I had heard about palliative care, which you can tell obviously that I hadn't. And when I found out about palliative care, I immediately scheduled an appointment, and that was the moment where everything changed. So I'll start off by telling you what I remember. And what I remember was the room where I met with the nurse. There were floor-to-ceiling windows and light poured in. It was such a stark contrast. So the rooms where we had typically met with physicians were so dark, so cramped, really an oppressive feeling, and just the visual of light coming in was so stunning. Of course, that alone wouldn't have been, what would have been so beckoning. The nurse who spoke with me exuded such kindness. It was something that I can still feel as I reflect on those words right now. And she described what it would be like for their team, which included a physician, a nurse like herself, and a social worker to come and meet with my husband. And I remember the day when they came to his bedside. As she said, the physician, nurse, and social worker with my sons, my mother, my late husband's sister, all gathered around. And the conversation that they had really talked to him as a person. They weren't interested as much in his symptoms or symptom management. They wanted to understand what it was like to have endured, or gone through a year and a half of life with this very debilitating disease. And they also gave my sons an opportunity to interact, to share what they were feeling. It was a very whole family dynamic instead of focused on symptoms. And at the end of that conversation, he clearly stated that he was ready to die, in those exact words. And that's when we found out about hospice. And that's when we found out about this building, which at that time was an inpatient hospice facility. And something that's also worth mentioning was how we were greeted, my sister-in-law and I, when we walked in. And the chaplain said, "Welcome. We're so glad to see you. Very few people have the courage to walk through these doors." And I was kind of aghast. And it was another sign that we were walking down a path that was not well traveled. The staff here were extraordinarily compassionate, respectful, and wise. And they were kind and supportive to myself and my sons, and to him up until he eventually passed away almost 10 years ago. And in hindsight, and also in reflecting in this timeline to make this presentation, it brought back a lot of memories. And what is still clear to me is how grateful I am that we found out about hospice. And adding our names to the list of probably what is one of the most frequent comments that people make, I wish we would have heard about it sooner. And that's really why we're here. So we can't turn back the hands of time, but I can do everything now within my power to use my voice and share my story and collaborate with this incredible group of women and resources that we have in the community to make sure that this information is not withheld and that you have choice and that your decisions are respected.
Hi, I'm Kathy Aquino, and if it goes out, I have no problem talking loud enough. My loss is more recent. My husband passed 2.5 years ago, and so in the middle of my story, I've got to figure out what the connection is between us. But I have notes, so I stay on track because I tend to kind of go down rabbit holes because I always want to flush out my story. But I didn't want to write it down because I wanted to be organic and from my heart, and whatever emotions came up, I wanted them to come up. So I apologize in advance if I trigger anybody if you've been through something similar. But I really think that this story is important to come from my heart and to go to your hearts. So we're very, very glad and very grateful that you're here, and because this is just, we're both so passionate about helping people and helping all of you maybe avoid some of the pain that we had, and just make a difference. Okay, I think I'm out. Okay, thank you. So my husband's name was Dave, and we were just living life, And in 2010, he broke his leg. Can you all hear me?
Yep.
Okay. I was a band director at one point in life, so I can, yeah. So he broke his leg in December of 2010, and that was kind of the start when you look back, because your vision's always clearer when you look back. And so he had a major clot that came after the leg, and his two legs were no longer even, so he had to wear a lift in one shoe, and so he started having back problems. He had problems where the rod and the leg stuck out, and he had a lot of problems with the ligaments popping over. There's a lot of pain, and so we were doing what we could do, going to chiropractors and craniosacral people to move the fluid out of the leg, and whatever we could do, because there was so much fluid in the leg all the time. But so he was a very vital person, a very big personality, lots of energy, and very high threshold for pain. So he didn't really complain very much. We did what we could do to alleviate these things, and he just kept chugging on with life and living life pretty normally. And so, you know, because sometimes you might wonder, well, how was it they didn't notice? Thank you. And we just didn't, because he'd been having like small problem after small problem, and we kept trying to take care of it. But by the summer of 2014, it kept piling up, small problem after small problem. His immune system clearly wasn't functioning. And Labor Day weekend, he had gone to the dentist and then just had some normal work done, and then the abscess. Of course, it's always Friday night on a holiday weekend, right? And I'm like going out of my mind trying to fix it for him, and it's horrible. And by Tuesday, I had given him a bunch of stuff, and it was kind of cleared up. But I remember him laying in bed that night just going, and this was not like him, but he said, I don't know what to do. I'm at my wit's end. And I was just like, and 2 days later, I was there, and I said, tomorrow morning, we're going to the doctor. I don't know what you have, but we're going to the doctor. So the next morning we did. We went to the doctor, and we hadn't been there 20 minutes. They took his blood, and they said, you need to go to the hospital right now. And they said, you have half the hemoglobin a man your age should have. He was 51. And we're like, because he wasn't feeling like that. And so we went to the hospital. We were there maybe an hour. They'd taken some blood and urine and stuff, and they came in, maybe it was an hour, and they said, your kidneys are in failure. And we're like, what? And so that started, they admitted him, and he was there, and he was fighting it the whole time. He was hanging around the nurse's station, and how long till I get out of here? And we started to learn what hospital protocol is, and well, it's better if you stay here, because then we can get you on the list to do this test. And they were compassionate. It was a small community hospital, and I really appreciate looking back that they didn't jump to the worst conclusions immediately. They started with the small things and started checking, and it wasn't that, and it wasn't this, and it wasn't that. And we started to see the oncologists coming on the floor, and words started to come up a little bit. And then we had to start taking more elaborate tests. And we kept digging our heels. We didn't want to go there. But that's what happened. We eventually took all the tests, and they confirmed he has multiple myeloma. And if you aren't familiar with that word, it's bone marrow cancer, and it's fatal at this time. And so there's a range of that. Multiple myeloma, you can catch it really early, and some people live a long time. That wasn't his case. I knew later from medical records that by the time we got to the doctor, his bone marrow was 99% cancer. And so I was really offended by how this happened. He was more in shock. So what happened is the doctor had gotten all the tests in, and he called us in. And I don't know where this doctor's humanity went or what classes he might have missed, but he came in and told my husband that he had multiple myeloma like he just won Jeopardy. And my mouth was about hanging open. And we didn't even know what it was, except I knew it was fatal by that time. And that's how he addressed it. And he started going on about all the things that would come down the pike later, and we didn't even know. Like, he started talking about stem cell treatments and this and that, and we were like, and my husband literally was just in shock. So we went home, and he started, some minor treatments, I think, there, but I was so offended by how he was treated. I said, we're not staying here. And so I went on the internet and I started researching, and I found what was considered, I knew he wouldn't travel to Texas or New York. He wasn't going to leave his family and do that to us. So I found the best local place that we could for his kind of cancer. So we went there, and I was very grateful because the doctors were uber compassionate, and that was a relief compared to what we just left. And so they were very kind, and we met with them on a Friday, and 2 days later, so you know this never happens, the doctor called it home on a Sunday, the doctor himself. So that's not ever good news. And he said, he gave us 2 more pieces of the diagnosis that we didn't have before, that he was missing the gene that fights cancer, and that he had also plasma cell leukemia because it all spilled out into his blood. And so he said, we need to admit you immediately. And my husband says, no, I can't do it then. I'll do it on Thursday because my work schedule. So that's still where he was at. And he negotiated for when he was going to come in and how that was going to go down. And so, and the doctor was pretty good, and then that worked out. He was able to work from his hospital room. What followed there was chemo started, and he started on chemo immediately, and the next 3 months he would go in for 5 days, 24-hour-a-day treatments with chemo lines, and then he'd come out from those 5 days and he would spend the next 3 weeks with chemo. He'd have a few days off, and then he'd start the schedule again. I did some other things on the side that kept him functioning, thankfully, so he didn't have many of the side effects you hear about, but he did have enough. He had, because he had that swelling in his leg that we could never work before, when you get massive amounts of chemo, they give you massive amounts of fluid, so they need to do that. Well, what it caused on him is he would gain 30 pounds of fluid in that 5 days. And so he was so full of fluid, it would move up into his chest, he could barely breathe. And I'll just be delicate, but as a man, there's certain parts of your body you don't want to swell like that. So, and I was rather appalled, and it was terrible. It was painful. There was times when he came out of the hospital, he always walked. He would never go in a wheelchair. And I'd have to pick his legs up to put them in the car. They were that heavy. But he never complained. He was so stoic, and he was going to beat this. And so that was for 3 months we did that, and they got his count numbers down to, they weren't what they wanted, but they were somewhat manageable for the next 6 months, and he just got on a chemo routine. They kept trying to get his numbers down where they wanted him to go. They couldn't quite get them there. So by the next summer, just out of the blue, because we didn't know how these routines went, or and we learned that when you went in the hospital, it wasn't about you. It's not like a hotel, so it's about them and their schedules. So you have to bend to their ways. And my husband and I are both relatively intelligent people, so we were like, okay, last month when we went in and we couldn't get the program started till 5 o'clock in the day because all these things happened, and then we couldn't get out the other 5 days until 10 o'clock, so this is what we're going to do this time to avoid this. We'd have a whole plan, and every time the plan would go out the window because something else would happen. And so it was never very convenient. It was all very difficult. So that summer we were told that he had, that we needed to go. So we now met the transplant team. He was fortunate, one of the fortunate ones. He had some donors. And he was able to go in, and he got his transplant in October of 15. And
bone marrow transplant?
Yes, a bone marrow transplant, yeah. And that is interesting. Somebody donates those if you have somebody that matches you. Not everybody has that, but he did. And it's very, just seems like a normal IV. It's not any big deal, and when I saw that bill later, I was like, oh. So, but at first it causes no problems, and then it takes a few days to work in, and then the problems can start. And when I speak about, sometimes it's not just our story, because I met other women and other families on the floor, and I saw their stories and what happened to them. And so he had a pretty rough time that first couple of weeks, and he was in the hospital about 5 weeks. And I sent him home, and he wasn't right. And if you've been a mom, you don't need somebody to verbalize for you when you know if somebody's right or not. He was not right. He was sleeping 22 out of 24 hours a day. And I would beg him to get out of bed. Maybe I could get him out by 2 o'clock, and I'd try to get some food and some liquids in him. And then he would stand at our kitchen counter leaning, sleeping. And so that's pretty much what he did the whole day. And of course that's not normal, that's not right. And I kept trying to wake him up to get food in him and this and that. And when we went in the next Monday for our treatment, I had noticed the day before that he started getting spots. And that was something that you were supposed to say something. So I said, you know, his back broke out and he's like this minor rash last night. Maybe you should see it. And the nurse was like, well, the doctor's not here. I'll come out in the waiting room and take a look. So in the waiting room, she lifts his shirt. She's like, it's not bad. Okay, we'll see you on Wednesday. I'm like, okay. So went home, and in 2 days it got considerably worse. So when we went on Wednesday, they admitted him right there. 2 days later, by Friday, it had spread to 90% of his body, and his skin was peeling off. All of it, all 90%, everywhere on your body, and including inside his eyelids. So he had the burn unit come up, and they treat you that way. They came to the floor, and it was gruesome, and it was horrible. And so that was November of 15, and on top of that, then, when they're treating him for all that, he ended up having a minor stroke, getting a pneumonia. That was all right at Thanksgiving. And the day after Thanksgiving, normal Black Friday, I was pretty sure he was dying. And he was not communicating or talking, and they brought in hospital staff to sit with him all night when I wasn't there, and I knew that he was dying. And as Gloria said, nobody was addressing the elephant in the room. I could feel him there. He wasn't talking. And I was like, I had no one to talk to. I didn't know what to do. And he was a proud man. He did not want anyone at the hospital but me. He did not want anyone to see him in that shape. Every time prior to this, when somebody from work called, he's like, I'm great! And he'd muster all his resources, and he would be, on the phone they had no idea what he looked like or how it was, but it was terrible. And so I knew he was dying, and I was like home. I thought, okay, what am I going to do? And I went in on Sunday, and I thought, okay, I'm going to do whatever I have to do. I might jump on him or cry or yell or something to get his attention to get him back. And somehow he came back. And he was gone a long way because he didn't remember all those days he was out of it. For 4 days, he didn't know what had happened, and that really disconcerted him. He did not like that. So I had to kind of fill him in on what had happened. And it was pretty awful. But I did get to bring him home before Christmas. He looked terrible in those pictures because he was close to death, and he looks like it. And but then we went into January. We had a little beacon of hope. We thought maybe he was pulling out of it. He got a little bit better, so I got him out for he walked one house length outside. I wrapped him all up, and I was like, we gotta exercise. You gotta get out and walk. So we walked to one house, and the neighbor was out there. People are loving and wonderful. And he was like, you're doing a great job. You look so much better than many people. He didn't. They were trying to encourage us. And so, so we had a couple of weeks where we thought, oh, things are looking up. But then we took a turn, and then his eyes started in February, they started going again, and we had to go to the ophthalmologist. And so what happened was the next 4 months, we were in the hospital 5 days a week, 10 hours a day. We would go from Kellogg Eye Center to the hospital, and every day they had to do things to his eyes that were horrible. And they were trying to save his vision, but he really had no vision left at the end. His skin would flare up on and off. So between a virus that he had going, the graft host is where you react to the other person's bone marrow. Yeah, so they were trying to balance between that, the graft host, this virus, and it was rough. We had nobody to spell us. I was there every day. I have 2 other children. My oldest at that time was just out of school. My college, I had one in college, and I had one that's still at home in high school. And I'm trying to balance all that. And I was supposed to be throwing a graduation party in June, a wedding in August for the other son. I'm like, how are we going to do all this? And I didn't, I just didn't know. I had nobody to talk to. And that's where I met Gloria.
So Kathy came to see me.
Try to work on this. We're getting batteries. They're on their way.
Kathy was referred to me. I practice a holistic form of healing called reflexology. And when Kathy came, it was
it was clear that really what she was most in need of was someone to help her understand the trauma of what she was going through. And it's a very difficult and disconcerting place to be someone in that position, to have to bring to her awareness what you probably can understand should have been brought to her awareness months and months and months before by many, many people. And because none of these people were able to or willing to do that, it looked like I was going to be that person. And her circumstances were so remarkably similar to me in terms of the cancer, but also in terms of Kathy's background or passion for holistic healing, which was really similar to mine. And I just felt like I was beginning to relive my experience again, and not wanting, as I said, another person to go through that. And probably for the next 10 sessions where I saw Kathy, I continued to plant the seed of awareness about palliative care. Have you heard about this? Does it seem like something that you would be willing to consider? And that was how we met.
So it took a long time. I wasn't ready to consider it for a while. And, but eventually I knew by April he wasn't going to make it. Now, my husband was not willing to consider it. My husband was going to live. He never admitted, even when he was going. Like, he never said, I'm going, I'm goodbye, because he was going to live. He's probably still living, still somewhere here, but not in the same way. But, he just never admitted. So he wasn't willing to look for it, but I needed help. And so, and none, as Gloria said, same experience. Not a single hospital personnel said anything about him passing, about services, nothing. Until the day before he had his final treatment, because I'd already asked, I went into the staff and I said, I need some palliative care. And week after week went by, and we'd see the same PA. She's like, I don't know why they haven't called you. Nothing. And I got a social worker in 1 hour. But the social workers at this hospital pretty much give you parking passes, tell you where the lunchroom is. There was nothing of any importance. I'm not going to say that's at every hospital, but that's what myself and everyone on that floor that I knew encountered. And so, this last social worker guy, he took care of a minor bill for us. He was a nice guy, but I didn't get what I was looking for. I wanted palliative care from what I had heard from Gloria and by then a couple of other people. And I used that term with my husband because I knew he couldn't hear hospice. And so I used palliative care, but it never came. And the day before his final treatment, I told one doctor who hadn't seen him in a year, and he looked at him and he said, oh my gosh, he looks terrible. I said, I know, he looks terrible. And my husband was most of the time like laying on a cot, like this, sleeping. So you could pretty much say anything, and he usually wasn't too awake. And I was like, and the man said, the doctor, he says, he said something else, and I said, I asked for palliative care many, many weeks ago, and I haven't gotten it. And he was appalled. And he said to me, you should have had this the day you walked in our hospital with the diagnosis he had. And I forgot it. So the next day he was admitted to the hospital because we didn't know then, but he came home from the treatment. He couldn't get out of the car. He couldn't walk. I had to have a neighbor come, and 4 of us got him into the house. I'm just trying to prod food into his mouth. And the neighbor said, if you need me to come over afterwards, come get me. We did. We couldn't get him out of the chair without a lot of pain. So I called EMS, brought him in, and once he got admitted, they said, yeah, his back is broken. Yeah. And so that was it. And I did get in-house palliative care at that point. And they were wonderful. I got 6 people, a chaplain, doctor, some nurses, social worker. That team was fabulous. And I can see where the kindness and the wonderful resource they are. And they said, what can you do for you? And I said, what can we do for you? And I said, you can listen to me. Because That's all I need. I asked for, and I told them the story. I'd asked, I'd gotten nothing. And I said, it has nothing to do with you. It has everything to do with, thank you, it has everything to do with these other people that didn't come through. And so, but they were kind and listened, and they said, what do you want to do? And I said, do you want to take him home? And I said, no, what am I going to do? And I knew, you know, he died 3 days later, so he never came out. And it was, you know, for a death, it was quiet and peaceful. And they were good to us in the hospital. They gave us extra room, and they were good to us there. But it was a shame what we went through, and I don't want other people to have to go through that. And so I'm very, very passionate, and I hope that Gloria and I have many opportunities that stem from anyone you know or anybody that hears this video in the future. We want to go and talk, and we want to make a difference. And we want to take that gap that exists between these wonderful hospice people and all the rest of us that are living life out here that will have to go through this with somebody we love, and close that gap so we can access that. So that's where my heart is, and I hope that each one of you can take this and it benefits you, and you can be a point of light out in our community and bring that to other people too. So thank you for coming.
Hello, my name's Raquel Clary Lantis. Can you guys hear me okay?
Yes.
No.
I'll sit up straight and talk louder. So I've been very fortunate in my life and my career to have been through a lot of different specialties in my training, and I grew up in a home with my dad's a doctor, and he's retired now, and I always thought we had quite a dysfunctional family, but he told me when I was a teenager that someday I would learn that we put the fun in dysfunction, and so kind of through my training I've also seen that our family's pretty normal and everybody has a story. And when I went through training, I also became a family medicine doctor like my dad. But what I learned during that time was that it was very hard for me to really find meaning and joy in my job, because I felt like I had to see people too fast every 15 minutes to try to be able to pay the bills in the clinic. And I also did hospital work, so just a lot of high anxiety, feeling like I was letting my patients down and not really being able to provide the care that I wanted to do. The nice thing about it was that I was able to, I was in rural Kentucky, so I was able to take care of my patients really from, you know, the clinic, the hospital, and then end-of-life experiences too, so I was able to do that whole spectrum of healthcare, but it became more and more challenging the busier I got. And my husband and I always use him when I talk, because he taught me a lot of things about being able to get to where I am today, but also a lot about the two people that have touched my life the most, that have died in my life, have been his sister and then more recently his father. And I always used to say, and I don't mean this to sound crass, but I used to say when I first got done with training that my biggest fear was that I was going to cause somebody to die because of something that I did. And now I look at it as sometimes I'm going to cause people to suffer by something I may not do or talk about with them. So I kind of come from it at a different perspective now after seeing the things that I trained and learned about as I've grown in my wisdom and experience with life. And then it kind of took me on some different paths in my training. And when we were in Kentucky and doing family medicine, I was at a Catholic hospital in 2005. And this nun that was also a patient, I was very blessed to know, I ran into her actually at a mall shopping, you know, because that's kind of your stress relief. And she came up and asked me if I would be interested in being part of a palliative care team. Well, I knew nothing about palliative care, and I wasn't that far out of training either, but I'd never heard of it before. I knew about hospice, but you know, hospice was what happened when somebody died. It was like very close to the end of their life. I had no clue about this in-between thing called palliative care, and it was pretty awesome to be part of that hospital because the Catholic health mission is very much a proponent of palliative care and hospice, and they're very mission-oriented. And I'm not Catholic, so I'm not trying to preach about Catholicism, but they were, part of their mission was that every one of their hospitals had a palliative care team, so they literally picked me, asked me if I would do it. I was very fortunate to be selected, a nurse, a chaplain, and a social worker, and they trained us all. There weren't that many fellowships at the time, so now it's a fellowship training. There were like 10 in the country at the time, so they taught us through a 2-year program of going through Hospice of the Bluegrass and doing part of this American Academy of Hospice and Palliative Medicine, so that's how I got my training. And I did that while I was still doing my family medicine work, trying to balance everything, take care of people, and still have time for my family and my own well-being. And my husband and I, several years later, actually moved back to Michigan. In 2009, we came back. And if you ask me, I said it was because we're Michiganders, number one. And number two, his dad wasn't well and we couldn't get him to live near us. So my mother-in-law's here, and she and her husband were very sweet to a couple of times when we couldn't get a hold of him, they would actually go to his house and check on him. So we finally ended up moving back to Michigan, and I worked as a hospitalist for a couple of years, trying to find my path, because palliative care wasn't really a full-time job, it was a part-time job at that point in my life, and worked as a hospitalist a couple of years and saw a whole different perspective about healthcare, and my work-life balance was better, but then I only saw people in this window of time where you're trying to make an impact and just really get them through the hospital and talk about what's happening in the hospital, and then you send them back out kind of not really fixing things, just kind of quieting a lot of things down. And at that point, I actually transitioned to where I was a geriatrician. Dr. Marvin Fields really kind of helped me find my path to where I am today. He was a family medicine doctor too that also did palliative and hospice, and he asked me when I did the hospitalist work for 2 years, and I missed knowing what happened to people. I didn't like not having that next piece, so he asked me if I would be interested in doing geriatrics with them, which if you would have asked me when I was much younger and in medical school, I would have said absolutely not, but I was very fortunate to realize how much I could learn from this man, and before he retired, and to carry on really what my passion was, to be able to provide care for patients and their families that really helps talk about not just the one problem that you're seeing them for, but how that problem fits into all the other things that are going on, and kind of looking at the big picture. And where I learned that no longer was my job to be fearful that I would cause harm to cause somebody's death, but it was more about trying to make sure I'm helping support and empower patients and their families to know how the health care we provide really fits into and kind of complements the care that they want. And that I explain it a lot as like going to get a new car, because sometimes people don't want to talk about these things, but when we go get cars, we might all want a luxury car, but we're really trying to find a car that really fits the needs that we have, that we can afford, that we can manage, and that we need. And it's kind of like healthcare. It's, even though we all might have a similar problem, it's how that problem really fits into everything else that we're dealing with and that our families are. And really the perspective of the big picture, not just, I call it a slice, and we look at the slice of the pie instead of the whole pie. And that's really what we need to be looking at, is what's going on right now in the big picture, and how can we get you through it. And when I talk to patients and their families, thanks to Dr. Fields, I learned a lot of pearls of wisdom about, and that's why I'm doing full-time palliative care, is when we meet with patients and families, it's to talk about how we can help them deal with a serious health problem, and how we can support them and empower them moving forward. And hospice, I think when I first trained, and also when I still talk to patients and families this day, is I think a lot of people think it's a 4-letter word, and it's certainly not a 4-letter word, but nobody wants to talk about it. And I tell people now, I tell everybody when I talk to them, the residents, the medical students, if we're all lucky enough, we'll all live well enough and long enough to benefit from hospice care, and palliative care really is a bridge to hospice care. A lot of people get them confused, and kind of like Gloria talked about in the beginning, they do talk about treatments now as curative or palliative, and which is kind of another stigma and hurdle to climb over when you're dealing with end of life, because the end of life is not supposed to be next week or tomorrow. It's really supposed to hopefully be for all of us at a time that we can maybe not always prepare or plan for, but to try to help prepare as much as we can to live as well as we can with whatever we're dealing with. And that's what palliative care does, and hospice really is a type of palliative care for end of life. But when I meet families and patients, the first thing we do, and even my colleagues, and I just had to give a medical update this past week at my hospital to all the specialists. We have to do it once a year. And the first thing I do is I explain to them again what palliative care is. And these are people that I work with every day too. So in our family meetings, we're constantly explaining palliative care. And that's kind of what I'll end with as I bridge to the next speaker, is what I tell our patients and families. And what we say is, I'm such and such, and we're here to help try to support you and your family, and when you're dealing with a serious illness. And when I actually started in palliative care in 2005, we called it a serious or a life-limiting illness or a terminal diagnosis, but now we say a serious illness, because healthcare is better, does help people live longer, sometimes with more suffering, but it really is, there are some things that we can cure to help people live much longer. And cure usually just means if we can get somebody through 5 years of treatments. Doesn't always mean we got rid of it completely, but I tell patients again that we try to help support patients and their families and empower them and not try to talk them into or out of anything. I think a lot of people get afraid and don't want to talk about palliative care because they think we have an agenda. And sometimes the medical teams want us to have an agenda, like, we don't want to do surgery on them, can you please talk them out of it? I'm like, well, please don't offer it. You know, we shouldn't be offering things that aren't going to help people and their families. So we don't try to talk people into or out of things. We try to support them, let them try to explain things and to know that there's choices and they have options. And we will make recommendations, but it really is trying to fit what's best for them according to the person that they are, not according to the healthcare system.
Thank you. My name is Mary Lynn Rush, and it's an honor to be here with you this afternoon. And I'm very moved by Gloria and Kathy's stories, and also by what you said, Dr. Clearmentis. So thank you so much. My background is as a home birth midwife, which I did for 25 years, and I worked with families who were taking a huge responsibility for their health care and making very informed choices and not outside of the mainstream, I guess I would say. And so when I retired from that 11 years ago, it wasn't a stretch for me to move into working with people at end of life who are also making informed choices and becoming very empowered to make decisions that are right for them. So I first started doing that through educating people about home funeral and green burial. And then through that, I got into talking about advanced care planning, which is thinking about the kind of care you would want at the end of your life in advance, and planning for that and talking to your loved ones about that and making plans. And then I heard about Death Cafe, and I realized that as I was going around doing presentations about home funeral and green burial, at the end of the presentation, and for the question and answer period, we would always just start talking about experiences with death. That's what people in the audience wanted to talk about. They would say, we don't have chances to talk about that very much in our normal life. If we want to, talk about it with our children, well, like my son did, he was 32, he said, "Oh, Mom, you're not going to die." I'm like, well, I am someday, hopefully not soon, but we should talk about this. And so, he finally let me show him where my papers were. That was as far as I got at that conversation. So I realized that people want to be able to talk about these things. And so when I heard about Death Cafe as a social franchise that was something that was happening all over the world, where people got together to eat cake and drink tea and talk about death, which really normalizes the conversation, and it's well upstream of any of the kinds of situations that you guys were talking about. I was already kind of doing that. So I signed on and started doing that here in Ann Arbor, and we've been doing that we've been meeting monthly for the last 6 years. So I invite you all to come to that. We meet at Crazy Wisdom Bookstore on the third Saturday of the month at from 10:30 to 12:30, Crazy Wisdom on Main Street. And we usually get about 35 people there at any given month. So then after that, I started, with a friend who's also a former home birth midwife, started a end-of-life doula training program. So if you want to learn more about that, my cards are over there, and you can visit my website and then contact me if you have questions. But that's just a little bit about my background, but really what I'm doing is I'm a community activist, I guess, and I'm bringing people together to talk about, in a death-denying culture, to talk about the one thing that we all have in common. And I have since then received a master's degree from Madonna University in Hospice and Palliative Studies. So, and I was inspired to do that after I read the book Knocking on Heaven's Door by Katie Butler. How many of you have heard of that book? Yeah, so she brings up a really good point, and what she talks about is if we want to make changes in how we do death in our communities, we need to do it ourselves. We can't rely on a top-down approach. We can't rely on medical care providers who went into the field because they want to help people, but have the realities of their jobs and the bureaucracies that they work for, and having to see a number of patients a day and not having time to get to know everybody like they probably would wish that they could. we can't rely on them to make these changes in how we do death in our community. So I think health and well-being is everybody's business, and we need to start from a bottom-up approach. So we need to create opportunities in our communities to be able to talk about death, to be able to care for each other, to be able to have compassion for each other in whatever. We're all dealing with issues, whether it's somebody that's actively dying or somebody that's just gotten sick, or whether it's some other issue. We can all do a better job in all of our community structures, whether it's our schools, our healthcare centers, our civic functions, our places of worship, our businesses, our workplaces, to do a better job of talking about what we're all going to face at one time or another in our lives. So we've mentioned words such as the elephant in the room, not wanting to be talked at, but be talking with. And I wrote down a few other key phrases. What can we do to close the gap? And I think it's up to all of us. And I'm here to try to encourage you all to think about that. And just by being here today and hearing these stories, I know you were going through your own things inside that's going to want to cause you to talk to somebody else, and I encourage you to do that. And find somebody who will listen and see what you can do, even in your own small circles, to change this cultural conversation. So I am not a celebrity. You all are, for being here, and especially these women for sharing their stories, and thank you for this opportunity.
So I think the new batteries did the trick. So we are at the point where we can open it up for question and answers. If you prefer not to ask a question, you want to write it down and maybe pass it to the end of this, the rows this way, we'll pick them up and I can ask them and answer it that way. Or feel free to raise your hand and we'll call on you and pass the microphone over. Does anyone want to start with a question? Yep, right here.
So, I've had a couple of experiences with human hospices, and it seems like the experiences that I've had are vastly different. Some provided some services, the other ones provided other services. So I was just curious, is there any regulation that goes on to mandate how hospice organizations function and what kind of assessments that they are giving these patients?
Do you want to let me stand
So hospice is actually a Medicare benefit, and it's actually an insurance benefit. It's covered most of the time 100% from your insurance, but what does it cover? So I think that's kind of what you're asking. So in traditional with Medicare A is what pays for hospice. So you kind of, that benefit goes to that. And what that means is instead, Medicare A, for those of us that may not know, is hospital coverage for health care, but when people transition to hospice care, it goes towards hospice. And hospice, what it covers at 100% generally is supposed to be pretty standard, but it really relies on patients and families to provide the 24/7 care for their loved one. And hospice tries to just add support. And generally it's services, and I know that I'm speaking in Arbor Hospice's house, so.
Okay.
It's all good.
Yeah.
It's all good.
Okay. That's
It's
okay.
fine.
What we usually tell patients and families what hospice covers is hospice is, unless you're a veteran, some veterans that are established at the VA have extra benefits, but general hospice covers any equipment a person might need to be at home to be cared for. Usually nurse visits, I say at least once a week. And they're usually there about 45 minutes to an hour, give or take. And then they usually you can have an aide about 3 times a week, and they're usually there about 45 minutes to an hour. So about every other day, somebody from hospice might be in the home. And that's kind of standard hospice care. And it's an indefinite benefit. It doesn't end like home care does, so it goes on and on as long as somebody might need it. And there are extra services, but different hospices have different services. So some of the services include chaplains and social work, and there are some doctor visits, but it's really done, and nurse practitioner visits, but it's really done through the oversight of the interdisciplinary team with the nurse visits. So the hospice is available 24/7 by phone, and they can come out more frequently if needed, if there's something that's changing or something happening, although they're trying to really empower the family to kind of anticipate things that might be needed, so they're trying to really add support that way. And that's kind of basic hospice support, but you're right, some hospices provide different things, and some hospices have extra services, like some might have, like when I was doing my geriatric fellowship at U of M, we worked with the VA and the palliative care team there. We had a massage therapist that rounded with us, and then there was also music therapy, so some have different ancillary services like that. And some patients don't want some of that stuff, so they don't have to have them, they're all kind of optional. I think the thing that gets tricky about hospice too, though, is sometimes when we get consulted, some people are very close to dying and they really are nearing the last hours to days of life, and other people might be able to get the benefit of hospice where you actually get the whole, I always tell patients, when you qualify for hospice, when you have a diagnosis and when we suspect you may have 6 months or less to live, but the goal is to try to get those 6 months and let's make them as good as possible, and to try to get time and live during that time. It's not all about dying and end of life. I mean, the really hope is to live as well as possible for whatever time you have left. But I think different hospices do have a little bit of different supports, and some have better support than others. But it also depends on your personal story and your personal situation and where that person is in the process of their life too, I think. So I think sometimes complicated grief and complicated situations, kind of like these two spoke about, it changes people's experiences about hospices. So I always tell people, I work for St. Joe's, we have a hospice, but I tell people it's your choice to pick which agency you want, because some offer better things than another according to what your needs are. I'm not saying one is better than another, but they just might be better according to what your needs are. So I usually tell people that, I work for St. Joe's, so usually we say we recommend St. Joe's, but it's your choice, number one. I tell people to talk to their loved ones who might have had or anybody in their community that might have had some hospice experience, to get a recommendation that way, because that helps. I think it's kind of like when you're looking to know where to, different things you might need in your life, like daycare or a doctor, you're going to ask friends and colleagues who they might recommend. And same thing with hospice. It is a business, bottom line, but it is there to try to help support patients and families.
Other services that are mandated by Medicare to be included in hospice are volunteers to visit, and also bereavement services. And some hospices are provided in a hospice location, and others, but most often hospice is provided in the home. And then there's something that's caught on lately that's really spreading. It's the idea of the hospice home, the hospice house, and that is somebody opening up their house to be a hospice facility and just take a small number of patients. So that's something to be looking for. I don't know of any in Ann Arbor yet, but I'm sure that's coming very soon. I know there's many in the Detroit area. The larger question is, what about palliative care, though? And palliative care has many different forms, because it's not an insurance benefit under many insurance companies. Some do cover palliative care, and most often the cost of palliative care is absorbed by the hospital or the agency that's providing it. So it could look very different depending on what agency you're going through. There's outpatient clinics for palliative care, and then there's inpatient palliative care teams at hospitals, and then there's home palliative care. Some hospices offer home palliative care. So that can look very different, and we can talk more about that if people have an interest in that.
We're going to do a question from the audience. Given the difficulties of getting palliative care, even with multiple requests, what strategies can we use to obtain these services, i.e. getting around medical staff?
I recently had the privilege of attending the 22nd Palliative Care Congress in Montreal, and International Congress there, and I went up to a doctor afterwards who was speaking about palliative care and how to get it, and I said, thinking of this event in mind, because this was last month, and I said, when patients are asking for it and not getting it, what can they do? And he took a tack that we really need to educate patients how to ask for it, and I was shaking my head thinking, no, it's not our responsibility as patients to know how to speak medical language to get this service that we're entitled to. But unfortunately, I think that's where we're at a lot of times. So what I advise people to do is just keep asking until you get a yes. In fact, don't leave, don't accept anything else but a yes and a referral. And unfortunately, most of the time, in order to get palliative care, you need a doctor's referral, which is something that you all need to know to advocate for yourselves. So what we're talking about is an environment where we're advocating for ourselves. And I think that's why you're all here, is because you want to learn how to do that. And so you can know that it's your right to get it and not leave until you get it, until you get that referral. That's the best I have to offer. Yeah, I see a hand up of a physician in the room.
I'm an oncologist, and it helps to know what motivates doctors. So, I'm a physician. One of the things that motivates doctors, believe it or not, it's really not money. It's being trusted, and one way to do that is find a physician with whom you have had a relationship. It could be years before. So you had a physician who you connected with the year before. Just think of somebody, and then express trust in that doctor. So not I like you, I think you're really smart, but I really trust you and I really need your help with this. And immediately the defenses go down. So you're not saying to a doctor, I don't, I really like you, or I know you get paid to do this, so it's good for your business. You say, I really trust you and I really need your help. Is there a kind of doctor who can help me with symptom control for my loved one, my husband, my wife, my daughter, my mother? And that gets you on the same side, so that it's not adversarial and you're not saying you can't do what I need you to do. It's that I really trust you to help me find the right kind of doctor who can do this. We've been going with life-prolonging treatments, aggressive treatment so far, but you're allying yourself with that provider, and that I think usually gets them not feeling defensive or like a porcupine or a hedgehog. Does that make sense? So you've found an ally, and there's not that defensive mode, and that usually works. If it doesn't, you can call patient relations, because they work for you.
Thank you. Would you like to add to that?
Oh, please, yeah, yeah.
I'm really appreciating that suggestion, and am also recognizing in my own experience, once I had become as familiar as I did with palliative care and hospice, when my mother was living in the city and was hospitalized and had serious heart problems, and it felt like the actual social resources of palliative care could be really advantageous for her. If you remember, I said I was advocating for the emotional support for my late husband. And her medical condition at the time actually qualified her for hospice care. It was not acknowledged by the nurse who was taking care of her, that request. So I asked another nurse who also didn't acknowledge it, and they said, oh, no, your mother's not there yet. And I went to yet another person, and yet another person, and yet another person. And if you remember that Dr. Seuss story, Are You My Mother? It was sort of like that, I'm going to keep going until I find that person. And I remember it was a cardiologist that happened to be there one afternoon, on a Friday afternoon when they're usually not there, who said, of course. So until that day comes that you're talking about, I really encourage you to be that advocate, to not stop until you get yes.
We'll go here and then here.
One quick note. I just wanted to say too that whenever anybody gets diagnosed with a serious health problem, so not a life-limiting or terminal illness, but a serious health problem, I mean, you really can't ask to have palliative care. It doesn't mean you have to come see a palliative care person multiple times. Sometimes it's just a one-time visit at that point in your life. But whenever you get diagnosed with a serious health problem, ask for palliative care if you're interested. I don't want to pressure anybody, but of course you can ask. Because I think that's one problem in palliative care is we see people too far downstream that when they come to us, they really need hospice, and that's okay. We don't mind helping bridge people to hospice, but it's really not there just for the end. It's there for the journey and whatever that looks like for you. And then one other thing too is I think sometimes when you're in the hospital and if you or your loved one go home with home care, sometimes a lot of home care agencies have palliative care programs, and they can have a palliative care team come to the house to see the person when they're on home care. So sometimes it's just a way to, and like I said, it's not necessarily an ongoing relationship if not needed at that time, but that's also an opportunity for people to have a palliative care support too, to help maybe make them understand or or really see what's going on currently that kind of fits into what the future may hold so that they can make sure that all of their care providers are really giving them care that's about them and not about a diagnosis. It's about the person that has the diagnosis, not about the diagnosis.
So my question is, how would you suggest, how to help someone who is the primary caregiver, an elderly person, or his spouse, and the person who's ill, her physicians have told the primary caregiver, it's time to talk with someone from palliative care. And the caregiver is the one who is saying, she's not there yet. She's not there yet. So how to help that person reach out to palliative care?
What most people don't understand is that when people get palliative care, they actually live longer. If you compare, studies have been done that show people with the same illness, the same stage of illness, receiving palliative care and hospice living longer. And that's really counter to what our popular culture says about palliative care or hospice. We have so many fears and misunderstandings built up around what palliative care and hospice is that people think that it's going to kill you. Like you go into that and then you're going to die within a few days. And so I think we need to start with education about what palliative care is and all the services it can provide, and when people are getting all of their needs met in a holistic way, as was described, the emotional services as well as the physical relief of physical symptoms, people can have easier time, better quality of life, and actually live longer. So the other thing I think we get into is as caregivers thinking we're the only ones that can do it, and it's meeting some need in ourselves, and that can get really tricky.
I think too that maybe that provider, and I mean this with the utmost respect, but they don't know what palliative care really is. Because I think you could even say to them, no, I'm not talking about hospice yet, I'm talking about before hospice, palliative care. I think we at least just have a consult or an info visit even. So just asking for that, because like I said, every single day I'm explaining what palliative care is to not only patients and families, but my colleagues and residents and medical students, and every single day that I work.
We're going to go. Somebody back here had the question, and then we're going to go there, and then we'll come back to you. Somebody tell me.
I'm a longtime hospice volunteer, and it was so transformational for me personally to learn how to be at a bedside and with death that I've gone back to school and I'm just about to finish my master's in geriatric social work. And I've had the opportunity to work in a major cancer center and geriatric clinic, and what I want to do is ask you to just clarify, because in my experience, social workers aren't empowered to make a referral to palliative care. It really has to come from the doctor, but I don't know if that, and I'm personally, I hope this can be a helpful question to everybody here. I'm actually doing my major sort of wrapping up my education paper on why people, there is research to show that people who finally get to hospice wish they had been there longer, and the average number of days in hospice where families can receive this support and comfort care that is what we all want for our loved ones at the end of life, it is shrinking. It used to be about 20 days. It can be up to 6 months, as you've heard, and now it's just a few days. And so people really aren't able to have that kind of closure in the way that hospice was intended. And so I guess I just want you all to know that you might have a social worker who really, wants to give you a hospice referral. But I think that the magic word that one of you said was, I finally asked a cardiologist. But I would like, I want you to clarify that for us all, because maybe it's different in different institutions.
So I think you're right, at different institutions, usually I'd like to think that we're more of an interdisciplinary team now in healthcare, so it used to be the physician up here and everybody else down here, but really in palliative care and hospice, it's an interdisciplinary team, and I consider us all on the same level. But I still think that there is this mindset that sometimes the order has to come from the physician. And some insurances, actually, you don't have to have a referral. You can call and get your own appointment. But I just don't want people to have an unforeseen expense. So I don't want to say that can't hurt to ask, how can you get a referral, and see if they can help get the order from the physician if it's needed. But if you can't, if the system doesn't allow, like sometimes nurses will put consults in our hospital, even though they're not technically supposed to, so we just try to make sure it's okay with the physician, and they usually are okay with it, but we still see patients and families that have asked for it, and then they still won't put the order in. So I hate, it makes me sad that even happens nowadays, but I know it just happened last month in our system where a family member passed away in the hospital, and we only helped like the last 2 days of life, and they've been there for 3 weeks. So I think somebody said earlier about patient care services, you can, I mean, the physician's not at the top of the chain anymore. You really can keep advocating through the nurses and the healthcare team, and if it's not, there are patient care services too. So I don't know that I have a better answer than that, though.
Maybe the social worker can say, ask your doctor, ask your doctor, ask your doctor.
Yeah, for sure.
Question.
I think I have somebody right behind you. Are you still good to ask your question? Okay.
So my question is, if palliative care isn't covered by insurance, and it depends upon the institution that's providing it, how do you really know or compare different institutions for what they can offer in palliative care? It sounds like you're kind of at their mercy for whatever they fund.
Yes.
Yeah. Short answer, yes.
Not much more to say than yes.
I mean, I can help answer that. I think what you do is you just find the providers that you want to reach out to, and you kind of have to do your homework. You have to call them, contact them, ask questions. They can help run your insurance and find out what your coverage looks like, but you truly have to reach out to every single one of them and kind of do a compare that way.
But palliative care, I thought someone said earlier that it wasn't covered by insurance.
Some do cover insurance, some do not. And it depends on what insurance you have too. Medicare does cover some Medicare. Yep. Okay, I think we had you here, and then I'll come. Or did you get your question answered?
No.
Okay.
Can you tell me the difference between palliative care and hospice?
Okay.
I know they overlap, sort of.
Differences between palliative and hospice?
Yeah.
Let's describe palliative care first. Palliative care is aimed at comfort and symptom management, and you can receive palliative care when you're still receiving curative treatments.
So you get chemo and...
You can get all the chemo and radiation and also receive palliative care. And it's provided, the patient and their family and caregivers are the unit of care, and it's the interdisciplinary team consisting of physician or nurse practitioner, social worker, chaplain, and other services, as depending on where you're getting it.
Yeah.
Hospice is a form of palliative care for when it's not expected that you would live longer than 6 months. And there's more services usually provided. And it's covered by all insurances.
Once you enter into hospice, though, can you be treated for things?
Yeah, that's what I was going to add too, is so I think you can have palliative, so kind of like I tell people, like if you're starting like today and you get diagnosed with a serious health problem, you qualify for palliative care from that time on. And you bridge to hospice when the treatment, whether it's curative or not curative, even just sometimes curative, is to try to help keep the disease, whatever it is, stable or calm down, or try to slow it down as much as possible. But when you bridge to hospice is when the treatments, I say, are no longer being offered or no longer benefiting you more, the side effects or harm are greater than the benefits of the treatment. So it's not necessarily even about curative, because a lot of the treatments we give aren't really curative. They're just to try to manage the disease. So does that make sense? a serious illness, palliative care can happen anywhere along the line, and then you reach to hospice when the treatments are no longer, the benefits of the disease-directed treatment are no longer outweighing the risk. But you still can get treatments, it's just the treatment becomes more of the focus on the comfort and symptom management that Marilyn was talking about is hospice. It's totally comfort and symptom focused, and it's really when patients decide that they don't want to keep going back and forth to the hospital and keep having tests and pokes and prods and procedures. When you bridge to hospice, you're wanting to focus on not that, more symptom management, try to live as well as possible for whatever time you have left, but forgo the in and out of the hospitals that I know that Victoria talked about.
Yeah. It may be that you might notice in different institutions that there's still a lot of professional people that don't know all this information, they're not clear on it, because the social worker that I did get immediately, I asked him, I said, all I want is some palliative care, some emotional support for us, and some physical support. It's just intense. And he said, well, you know, then he probably won't get any more treatments of any sort, including an IV. And he had a white blood cell count of like 1 most days when we went in. Every weekend I thought he was going to die. And so getting into Monday was really important to get a few more white blood cells pumped in. And the guy was like, no, he won't get any more. I was like, not even an IV? I mean, like, I'm not expecting him to live or be cured. I don't want him to die. Yeah, I don't want him to die because he just dehydrated, you know, or, but so he didn't know that. So I think that you might run into that also.
We're gonna keep your hands up here. And then
I'm curious if a referral is required to be entered into a palliative care program? And what does it say on that train ticket? What are the things that are gonna enable you to bridge to palliative care? And I guess we've covered exactly. I know about palliative care, but I feel like I know less and less the more I listen. Give me the textbook definition of palliative care. How do you get to it?
How do you get to palliative care? I'm not even sure. So
Referral is required?
ask for it.
Okay, yeah.
I think, you know.
Yeah, I think you just have to ask for it. So you don't always need a referral, it depends on your insurance. And I'm sorry, I can't even speak to specific insurances because as soon as you learn what one insurance does, it changes next week. So I try to be cautious about what I say insurance will and won't cover, but a lot of insurances do cover palliative care and a lot of insurances don't require you to have referrals. They just try to recommend them so that your main doctor knows what's going on and you hopefully have that kind of relationship with them to be able to ask for a referral and get it, but as we all know, sometimes it doesn't work that way. So it is okay to have the social worker, the nurse, and the medical assistants and all the care teams, even friends and family tell you to ask for one, you should ask for one, and if you don't get it, keep going up the chain till you get what you need.
It's sad that at the time of most need in our lives is when we're having to do the most research and garner these resources and find out things for ourselves, and I hope that changes. But even, it is changing month to month, it seems, because like my information is outdated from what I learned even just earlier this year. So it's really hard to have a comprehensive answer for that. So if you have anybody you can identify in your circle of support that can do research for you, if you've got that daughter-in-law who likes to Google, or if you've got that 12-year-old grandson who's good at teaching you how to Google, like I do, identify somebody who can take care of that aspect for you while you're dealing with all the day-to-day coping of the rest of the care that you're providing. I would highly encourage you to really widen your circle of support at that point to get help.
That made me just think of a website too. There is this website called getpalliativecare.org, and it's completely designed around how you get palliative care. Go back here.
So I am caring for my third family member in 3 years who has just entered hospice. And in the two previous cases, they were both at religious institutions. And In both cases, despite a diagnosis of metastatic cancer in the abdomen and the lungs and the breast for the one, and the other one who had, basically their colon was closed, so they had a tube to drain. Hospice was, and palliative care was never mentioned, and hospice was not even mentioned, to the point where I had to corner a physician, not a physician even, I think a resident in the hallway, and they finally said to me, and I felt like I was doing a drug deal or something, because they were like, yes, you might want to think about hospice. So what I'm curious about is that, should I be thinking for institutions, looking at one that is not religious-based? Is there a conflict of interest for staff? What is that possible conundrum that could be happening for the professionals with their own personal, are they supposed to set aside their personal religious beliefs if they're working in a religious institution? That's something that I'm just sort of thinking about for this third individual, who right now is receiving hospice at home, and that will probably take care of things, but who knows, so. And if either of you were in religious institutions or not for your care, so.
Us?
Yeah.
I was just we were just in a major hospital.
We were in a major public hospital, that's all we got.
And yes, I mean, I would think that St. Joe's would be a religious institution. Would you agree with that? I mean, it didn't feel religious, but there are crosses, there is a chapel, there are services conducted. At no moment did I ever feel that anyone was preaching religion. It felt very non-denominational.
Did you also mean though that you felt like in these religious hospitals, they weren't talking about things that you felt like should be talked about? Is that?
Well, I guess the thing that I'm wondering about is that we've seen in recent years physicians refusing to offer treatment because of it being in conflict with their personal religion. And so I understand very well that the medical profession favors curative over palliative techniques. I'm also wondering what this particular element may be adding to this conversation and contributing to the difficulty in getting care.
So, because I think at St. Joe's, which is where I work, and I'm not Catholic, like I said, but I do consider myself a Christian. I think it is a faith-based institution, and they're very supportive. I mean, it's the most robust palliative care team I've ever been a part of. They really fund our program really well. That being said, I don't know the religious belief of the majority of my colleagues, so just because we're in a Catholic health system, I don't think everybody is Catholic or even has any faith-based necessarily intent with the work that they're in. So I think that a lot of the providers, a lot of us are employed through the health system, but that's not part of our requirements, is that we're Catholic to work there. So I think in healthcare, first and foremost in healthcare, we talk about this is the problem and this is what we do to fix the problem, and we don't necessarily look at everything else that goes into it. We are looking at it, but we're not paying attention to it. So I think that's really the bigger picture, is whether you're in a religious institution or not, is that we're trying to fix things no matter what, even when we can no longer fix them. And some of the things we're doing to try to even attempt to fix them is causing much more harm and detriment to patient care than anything else that we're talking about. Is that sort of?
I think institutions differ is what, just so widely that we can't make any blanket statements about that. But I'll share a story with you. My uncle was in a hospital in Florida called Doctor's Hospital, and they didn't even have a palliative care team. So that's a whole nother argument or problem that we have, issue, I think, of that whole hospital called Doctor's Hospital didn't even want to refer people to palliative care at all. So that's a problem, especially in Florida. I mean, we don't have, how many of us go there to die?
we're gonna do a quick question, hand it in, and then we'll get to you two here. Is there any thought or discussion about having a palliative care ER? So people committed to having this option, avoid getting on that medical treadmill.
The first question I have is, any of you here working on palliative care teams, do you have 24-hour phone availability? That would be the equivalent of perhaps what we would have right now in terms of, if you have 24/7 availability for answering phone calls, that would be a place to start.
And I know, I can speak for Arbor, who has a palliative program, and while we do have a 24-hour number, we do try to educate our families that we are not that ER phone call. So if you are having an emergency, our palliative care program, and I don't want to speak for anyone else's, but our palliative care program is not set up that way. So if you were having a true emergency, you would still reach out to your EED.
I also wonder what orientation this question comes from. We have something developing in our state called MyPost, which is going to be standing medical orders that you can work on with your doctor that will cover you no matter where you end up in whatever care setting. That will be the medical orders that you want observed, whether it's a DNR order or no artificial hydration and nutrition, or comfort care only, or curative care, or whatever. That will be transferable to whatever medical care setting you're in. So that will also go a long ways towards, if you've had these conversations and you know what you want, but then you're visiting somebody in Detroit and you go to a hospital there, is it transferable? It will be. So that is coming in the next year or so.
Related to that.
Yep, sure.
Related to that, if you want to if you're looking for a way to sort of walk through all of the decision-making that you might be presented with in an emergency, especially for people who are elderly and don't want the really invasive treatments, there is now a website called prepareforyourcare.org. And it has wonderfully simple screens with little videos that walk you through the many kind of treatments that might be offered to you. And you can indicate on the you can use it to indicate your preferences. And by the end of this year, I just listened to a podcast by the medical team that was involved in researching and creating this yesterday. And they said that by the end of this year, you'll be able to input your choices and it will instantly populate into a form that is legal in your state of residence. And if you spend half the year in Florida, you can have it populate the forms for Florida, because every state is different. Every state has a little bit different forms. So it's called prepareforyourcare.org.
Hi, so my question is for caregivers and patients who have a distrust of the medical system. How do you kind of explain palliative care and advanced care planning? Not necessarily I'm afraid of dying, but specifically I don't trust my doctor, and so I feel like if I do this process or I complete this paperwork, they're not going to fight on my behalf or do everything that I would want them to do. So how do you navigate that distrust of the health system and explain palliative care and advanced care planning?
I think what advanced care planning does is actually give the control back to you rather than give it to anybody else. So if you can explain it in such a way that if you do advanced care planning and you're choosing an advocate from within your own circles that you trust, you're empowering them to be able to legally speak for you if you can no longer speak for yourself. And so just that simple explanation hopefully would enable people to change the way they look at it into, this is what I can do to have the most control, and not look at it as giving out control. In Michigan, the living will portion of your advance directive is not legally binding, so what you write there is going to guide the person that you choose to make decisions for you, but it's not meaning that they have to do those things. So they can make up their mind in the moment what they want to do for you. So I think that will help people to understand that. Most people don't know that.
Hi, I just wanted to share a positive story. So my mom died when I was too young, and it wasn't a good death. And so when my father had pancreatic cancer, which was unfortunately pancreatic cancer in 2005, you knew that would be a death sentence. And he was living elsewhere, but when the treatment wasn't working anymore, we brought him to Michigan, and he moved into my home. Before that happened, I came over here, and I don't know what Arbor Hospice offers now, but in 2005, I was able to make an appointment to go in and say, look, I don't know anything. Can you tell me what I should be thinking about as we approach this death? And they gave me things to think about. When he came, we didn't start right away. We saw a doctor at Michigan, and at one appointment, I heard my father, he shocked me, and he said to the doctor, okay, I'm ready to die now. And he had not said that to me yet, and the doctor said, well, sorry, I can't help you with that, basically. But then I knew it was time. And we just had such an outrageously good experience with Arbor Hospice then. So I second what you said earlier, which is the thing, don't wait too long. So what I was helped by was much more important than what my dad got, and that was guidance on how to provide what he needed, know what was coming, anticipate things, and you're given, a kit to take care of things that happen in the night. And I don't know, I can't even tell you how many layers of support were provided. So don't wait too long. And he didn't die right away, okay? So he lived for a while at my home, and then one weekend, it was clear he was just completely fading, and that he was in pain that that hospice was not able to control in my home anymore. And so we came to here, which was inpatient. I don't know if it's still inpatient. And okay, so he died 36 hours after coming into this facility, but he wasn't hospitalized at all. So I just wanted to bring that up in the face of these bad stories to say you can have a good story and get the support you need, and don't be afraid to ask for it. I can't promise that you'll always get the referrals, but you can also be proactive. So I was just so glad that I made an appointment early, just saying, look, I don't know anything about this. And my mom was already gone, I'm the big sister. I knew I was going to have to be the one to do it. So I just reach out, get information. It doesn't have to be a bad story.
Thank you for that. And I think your point is really a good one. Not just all hospice agencies have resources to be able to offer help and support before you might be ready for it. And I think that's part of what we're doing here today. You're here to learn more about what's out there, what's available. Where do you turn to when you get help? It's almost like a lot of people will wait until they're in crisis moment, and then they're like, where do I go? What do I do? What do we need? And that's really hard to make decisions, to know where to go, who to trust. If you can gather that info and just keep feeding yourself with materials and resources and different things, maybe that crisis won't feel so scary if and when it comes. So just know that at all hospices I know, they have people who will gladly offer help, support, come out and meet with you, give you education, help you to point you in the right direction so that you're getting on that right track sooner rather than later.
I have a comment. Listening to your story sort of affirmed an idea I had listening to all of you guys. Maybe if palliative care, if it's so difficult to get somebody in a hospital setting to listen to you and give you the referral, maybe you just, now that we all know about palliative care, go online, find the phone number for, if your loved one's at U of M or St. Joe's, find the phone number for the palliative care office, call them up and say, how do I get to you? like, who's the cardiologist? Who's the person? If I need a doctor, who is that person? You know, just tell me. How do I get to you guys?
I'd like to apologize up front for being a physician speaking in this group, but I have the honor of serving as the program director for a statewide consortium of oncologists. We have 95% of oncologists in our group, and we pick quality metrics that we measure, and we don't measure for measurement's sake, we want to improve care. And our measures for the last couple of years and going forward will be looking at the proportion of people in an oncologist practice that die, who die on hospice. That's an outcome measure. It's not just a process measure like documenting pain and what you did for it, but how many of your patients who died on hospice. And the proportion in our practices right now is about 55%, and it's the same whether or not it's a Catholic health system, so I wanted to let you know that. So that's better than I thought. I thought it was going to be about 30 to 40%, so it's already getting better since we started measuring it. And another measure is discussing hospice, because the doctors were saying, I discuss it all the time and the patients don't want it. So I thought, well, let's get them more comfortable discussing it. And also palliative care referrals. A lot of practices have no access to palliative care services. A lot of the remote rural areas in Michigan have no palliative care providers nearby. So we're starting telemedicine, because you don't actually have to examine a patient to be able to provide symptom control. The biggest thing, I feel like I'm swimming in a room of people who are on the other side where they want palliative care and hospice services. What the oncologists tell us, we do regional meetings, is that patients don't want to go on hospice because they feel they're being abandoned. So that here are their reasons and their barriers to referring patients is that if I bring up hospice, it's very stigmatized. They feel I'm abandoning them. They're just going to leave and go to another oncologist who will give them more chemotherapy, or heaven forbid, they'll go to Cancer Treatment Centers of America, which to us is a tremendous failure because that's a for-profit treatment center. Or if they're up in the UP, they'll just go to U of M and somebody will always give them chemo. That's where I practice. Somebody will always give them chemotherapy there. Or they'll go and they'll do something else to keep getting treated because I have abandoned them or given up on them, and they don't want to feel that way. So our solution at our coordinating center is to introduce hospice very, very early to destigmatize it and say, just get a consult, learn more about it. And the hospices will always do that. But you're on the other side where you're saying, please give us these services. So what we would love to see is you being ambassadors, where you're out in your communities, you know somebody who's been diagnosed, saying, you look great, you feel good, you're still a candidate for anti-cancer treatment, you're not a candidate for hospice, but this is the time to learn about it when you are in control, and hospice gives you that control, because control is something very American, and it's also what we have when we're in a place of privilege, unfortunately, right? Like a lot of people who don't have that privilege don't have control, unfortunately. But oncologists would love, most of us would love you to ask us about hospice and give us permission to broach a subject we often are terrified to bring up. This is what I'm hearing when I go around the state. And again, it's a very good quality of care. So I'll shut up now for the rest of the session.
Thank you. That's good perspective. I was a hospice nurse for many years. I got my training here at Arbor Hospice a long time ago. Wonderful place. And the way I approach it with a lot of my people, I did home care for many years too, is that you have, okay, here we are in plan A, what's your plan B? And people would sit there, and I came, when I did home care, we always had to discuss, planning. And there were some people that had been married for 50 years that had never talked about what they did and did not want. So that was a great way to open a conversation. It's like, okay, as soon as we talk about it, it's going to happen, And also the elephant in the room, when I'd go in to admit people to hospice,
okay, we do all the preliminaries, and I say, okay, now we're gonna talk about the elephant in the room, death and dying. And you wouldn't believe how many people would go, finally, you know, after going through all kinds of experiences with their medical team. So, and I think that it sounds really good, and I agree. It's like, you always have to reassure people that if you start talking about palliative care and hospice, that you're not giving up on people. And I think that comes down to a responsibility for people in the community. I talk to many pastors, hey pastor, how about talking about death and dying? And they kind of go, you know, but it's like, it's really a good idea to be talking. I mean, what I've been going through recently, I'll just give a brief personal thing, is that I have a will that I had a long time ago when I got divorced. My youngest daughter was 12. Now I'm recontacted the lawyer, and I want to do a trust. But I also want my daughters to be with me. I have 3 daughters, and have they say, oh mom, you talk about death and dying all the time. Well, no I don't, but I think that I want to know, and what it came up in my sort of rethinking my, you know, my future, is that I want my daughters to be able to make the right decisions, you know? And so they need support doing that. And I don't really have it. I said to somebody, I said, well, I need to find a doctor that will be there for my daughter. And they said, oh, that won't happen. I mean, so, yeah, I think we all need to be talking amongst each other and our families, because I used to tell people when they'd have grandma or dad in the living room in a hospital bed, and all the kids are there, all the grandkids, this is a great gift to your family, because everybody's going to have to go through this. So as much grace that you handle this situation with is a great gift to everyone around you. And that's my point. I'm going to step off my soapbox. So.
Thank you much to the physician who just mentioned that. And I think it's great that you're all thinking in that direction, and I just wanted to give you something else to think about, another perspective. Since my husband was relatively young when this happened to him, and he wasn't at all thinking of dying, he never would have been open to it. I don't even think if they'd come in the room the last day that he could speak, he wouldn't have been open to it. But I was, and I needed it. And so if you can let those physicians know that maybe it's not just the patient. Because when we entered the hospital, since we'd only known he had a diagnosis for about 2 weeks, I was still in shock too. And so if somebody had come and said, and really been, you know, kind, but right in our face about hospice and palliative, I too would have been like, whoa, what are you talking about? Because I wasn't yet ready. But, you know, I could have had a pamphlet in a package, or, and at some point along the line, it would have been great. So, you know, and maybe the caregiver that you have to address, you know, that's another perspective for them to think about, because it's not always, maybe the patient never will, but maybe the caregiver would be really open. Because it's a tough place to be in caregiving if you haven't. That's why I saw Gloria, because I was starting to fall apart. I was his only support, and I needed, so I would drop him off, and I would run see her to patch myself together to take care of him.
Sometimes the caregivers put a big stop sign up, the patient's ready,
yes,
and the
it can be
caregiver's
the
not.
opposite. Yes.
I'm really appreciating where this conversation is going, because when Kathy and I started our conversation back in the spring, it looked like this really teeny topic of where our personal stories overlapped. And as we kind of ventured out and met Dr. Raquel and later Mary Lynn, all of a sudden we understood that this was huge. And it wasn't just about our experience. There was the experience from the physician side that you were mentioning. There was the position of you not being ready to hear. And it feels like this intersects with what you're bringing to the community, Mary Lynn, the Death Cafe, that there's a need for, you know, honest, candid conversations and opportunities to destigmatize and normalize these conversations that we all need to hear, because we ultimately one day will be facing this ourselves or with people that we care dearly about. So what became this this tiny idea we see has, all sorts of spokes. And I agree that we can all be ambassadors in the area that speaks to us to make these changes and be these points of light that you were referring to before.
And how beautiful, Gloria, that when Kathy came to you, you were willing to go there with her, to take that journey with her and talk about it, even though you may have been feeling like, wait a minute, I'm not a palliative care specialist, but you had been through your own personal experience. So you create community and support wherever it is, and not just, oh, I've got to seek the ideal person. And so all of you may be able to be that kind of a supportive person to somebody else now, even if it's just a mention of a resource or something like that. That is something that end-of-life doulas do as well. If you want to learn more about what end-of-life doulas are, my card is back there, and you can look at my website. But I have a blog post up on my homepage about creating compassionate communities. And so I think that you enacted that, Gloria, when Kathy came to you. You were that compassionate person, and every one of us can be doing that for somebody else too, and that's what it's going to take to really make change. So I'm really inspired by this conversation as well. I know all of you have a seed planted in you that you're going to, use however you can now to also help create change.
And with that, I think we will complete this. So thank you all again for coming, for being here. Yeah, sure. No, that's okay.
So when I was saying that this, idea expanded from a tiny seed, I want to also mention that there are palliative care and hospice services available for our beloved pets. And if you would like to know more about that, I'd like to introduce you to Dr. Monica Turen, who you may want to reach out to after this presentation, or if you look her up online.
All right, everyone. Well, thank you so much again. Again, resources are on the table. There's some contact information, business cards. We still have some snacks in the back, so take a cookie to go. And thank you all again for being here. We greatly appreciate it. And thank you for our speakers.